Good afternoon and welcome. Before we get started, I just want to show you my disclosures here. I am a consultant and have received research support from the Musculoskeletal Transplant Foundation. This did not bias any of the content of this presentation. What I'd like to do is talk to you a bit about the basic science of platelet-rich plasma, PRP, what surgeons need to know, and try to frame this particular lecture in looking at some of the variations that occur in the different PRP technologies and see where they might have an effect on the healing of soft tissue or connective tissue augmentation. There are many different PRP technologies out there, and while we're not going to address each one specifically, I'm going to generically talk about how these PRP preparations vary and what impact they may have on your connective tissue augmentation. I think we can all agree that PRP has a long history of safety and efficacy in both dentistry and cosmetic surgery. So we know this is a safe technology and in certain instances has been shown to be very, very efficacious. This promise has led to the use of PRP in a variety of connective tissue or orthopedic pathologies, ranging from lateral epicondylitis, plantar fasciitis, Achilles tendinopathy, venous ulcers, and even osteoarthritis. Now, the clinical outcomes of these are somewhat varied, and we're not going to address that today, but rather we're going to focus on the basic science attributes of PRP and where they may fit into each of these different pathologies over the course of time. I thought it was of interest that PRP is so popular that it's even advocated for use in hair restoration. Before we get too far into the specific PRPs, let's take a little bit step backwards and talk first about platelets. What you need to know about platelets is these are small materials that are in the blood. They're about 2 to 4 microns in diameter, and there's a variation between patients, anywhere from 150 to 400,000 platelets per microliter. So not every one of your patients are going to exactly have the same amount of platelets per microliter. I want you to remember that they have a 7-day half-life. They're not around forever. They turn over anywhere from 12 to 15 days. And besides having the factors that are involved with clotting, they also contain growth factors. I like to think about platelets as bags of marbles, the platelets being the bags and the marbles being the growth factors that are released when the platelets are activated. The different growth factors that are there's a myriad of growth factors involved with the initial phases of wound repair, but the 7 that most of the people talk about that are really focused on connective tissue are seen here. Again, at any point in time in the literature, people have looked at individual growth factors and their role in connective tissue repair. Here we have what Mother Nature is providing for connective tissue repair, so that makes PRP all the more stronger because it's a cocktail of these growth factors. The other P in PRP is the plasma component. We don't talk about this that often. I think it's extremely important because the liquid or plasma portion of PRP basically contains a lot of the proteins involved with tissue healing early on. Fibrinogen, fibronectin, different adhesion proteins that are very, very important. So I think this component, along with the fibrin scaffold, which we'll talk about in a bit, are real key to those early phases of wound repair and are an integral component of any PRP preparation. As we said, or as we noted, to make PRP, you really have to put in an anticoagulant. We can't let that coagulation cascade happen because that will degranulate all the platelets. And so basically it's a pretty straightforward technique that you're all familiar with. We prevent blood from clotting by ionizing the calcium or chelating the calcium and preventing the catalation of prothrombin to thrombin. If we can do this by chelating the calcium, we can keep these platelets in suspension as well as the red cells and the white cells in the plasma component of PRP. Separating out the PRP components is also quite simple. It's based on a basic physics principle in which we can eliminate or sediment, if you will, out the different components of blood by spinning or centrifuging the PRP at different speeds. And the physical principle that's involved with sedimentation is the idea that sedimentation rate is basically determined by squaring the diameter of the material. For example, a red blood cell is about 7 microns in diameter. We square this, the unit is 49. If we take a platelet, which is much smaller, and square it, that number is 4. So simple math tells us that the sedimentation rate of red blood cells is approximately 12 times that of platelets. So the red cells will sediment out faster than the platelets, leaving the platelets in suspension. And that's very, very important to understand that each of the different PRP technologies utilize a different amount of blood and utilize a different kit and probably utilize a different centrifugation speed. And so the idea of each kit is important to utilize the centrifuge that comes along with that kit. Once we spin that down, the initial spin, the soft spin, so to speak, you separate out the plasma and the platelets. The platelets are suspended in the plasma and sediment out the white blood cells and the red blood cells, or the vast majority of the white blood cells. By definition, this is always a problem or somewhat of a confusing terminology. The PRP is basically defined in its most simplest terms as an increase in the concentration of platelets and obviously their associated growth factors over serum baseline. So even a 1.5-fold increase can be called PRP, or platelet-rich plasma, where we have an increase in those platelets above baseline. Now, we have to remember that is simple enough, but when we apply it to all the different technologies that are out there, there's going to be some variations in that. And now we're going to get into some specific differences among the techniques that are out there in terms of various aspects of the PRP composition. First of all is the volume of blood you take. Some specimens or some techniques utilize a small amount of blood, 9 cc's. Others can go up to upwards of 60 cc's of blood. And what you have to remember is that the final platelet, in this case if we're also talking about growth factor concentration, will be dependent upon the amount of whole blood used, the platelet recovery efficacy, and the final volume of plasma in which the platelets are suspended. Some technologies suggest that their particular procedure has more growth factor than somebody else. Simply speaking, it's because they take more blood. For example, if we do a simple mathematical exercise here, I think this allows us to elucidate this particular point. Let's say we take 60 cc's of whole blood. In that 60 cc's of whole blood, there's going to be an X number of platelets. That's going to vary between individuals, but let's say in a single individual we have a certain number of platelets. Now, if I'm able to centrifuge that material, that whole blood, and concentrate all those platelets into 1 cc of plasma, I'm going to have that same number of platelets in now 1 cc or 1 milliliter of plasma. So theoretically, this could be a 60-fold increase in platelets over the whole blood concentration. This is almost impossible to do because the platelet efficiency, harvest efficiency, is difficult to do to get 100%. Plus, again, we don't want to concentrate the plasma that much, and we'll show you why here in a second. So when you think about looking at the different techniques, you need to ask, what is the initial volume of whole blood that is used? What is the platelet recovery efficacy of that particular technique? And what is the final plasma suspension volume? Because we can vary that quite a bit, and obviously that's going to vary the concentration of platelets vis-a-vis the growth factor concentrations markedly. So again, you have to think of all these 3 different components when you're determining what the platelet concentration is. Remember that the increase in growth factor concentration is not always the same as the increase in platelet concentration, because we have some growth factors that come in, that are in the serum, also come in from other factors, other sources that are not platelet derived. So don't always think that just because we have a 10-fold increase in platelets or a 3-fold increase in platelets, we're going to have a 10 or 3-fold increase in a specific growth factor. That doesn't necessarily happen. Well, we talk about concentrating the growth factors and making them very concentrated within the platelets. Can we have too much of a good thing? Is it problematic to have a high concentration of growth factors in a small amount of plasma? Well, yes, it is. There's plenty of reports in the literature, elegant in vitro studies, that have shown that the growth response curve or the dose response curve, I should say, of growth factors is not linear. In other words, you just can't add more and more and more growth factors and have an increasing effect. In fact, they usually reach a threshold level depending on the growth factor and the cell in question. For example, this article by Lee shows that once you surpass 8 nanograms per milliliter of TGF-beta, that effect starts to drop off. And here, when we're talking about the effect of platelet-derived growth factor on bone induction, we can actually see an inhibitory effect of higher concentrations of this particular growth factor. So it depends on the growth factor in question and the target cell in question. So a little bit of growth factor is good, a lot may not necessarily be better. It's dependent on the growth factor and the cell in question. One of the nice things about PRP is that it produces the entire complement of the serum-based growth factors that you have in the body. And that's really, really good because we want to have that cocktail of growth factors. They're synergistic. They work together. And Thermopolis has shown us that combining growth factors led to increased cell proliferation compared to a single growth factor application. This synergism of growth factors between themselves is extremely important because this is the way Mother Nature intended the healing response to occur in the midst of this cocktail of growth factors. Important also is that in PRP, growth factors are present in the same proportions but in higher concentrations, as in normal serum. For example, we may have 2 parts PDGF to 1 part VEGF to 3 parts TGF-beta. This is the way it is in Mother Nature, or some component of that. And it's important because people have shown that if you mess up this ratio, if you mess up these proportions, you can actually drive the repair tissue to more scar as opposed to a more reparative type of tissue. So altering the ratios of the different TGF-beta isoforms can induce scar formation. So that's a key component and a nice attribute of PRP. All those things being said, that when we get into specifics of PRP, we find out that now we start to see a lot of variation in these PRP preparations. As we alluded to, the level of platelet recovery, the volume they use, we've already talked about that, is different among systems. Also is the inclusion or exclusion of white or red cells. Specifically, white cells, I think, have been the topic of conversation most recently because some of the PRP preparations are what we call leukocyte-rich, others are leukocyte-poor, and some have really essentially no leukocytes at all based on their processing technologies. The question is are white blood cells in PR preparations beneficial? Is this something that's good or something that we really want to steer away from? Well, it depends on what you want to read into the literature. I think you can make a case either way. I think if you look out there, white blood cells are known to play a key role in the initial phases of inflammation. So in the normal wound healing process, we need white blood cells to help initiate those inflammatory processes that are so integral to the early repair phenomenon of tissues. White blood cells can also inhibit the growth of some, but not all bacteria in vitro. Things like Staph aureus and E. coli has been shown to be inhibited by white blood cells, but Klebsiella, Enterococcus, and other Pseudomonas organisms have shown not to have an effect on these particular organisms. So some bacteria are inhibited, others are not, so it's not an all or none phenomenon. White blood cells have been shown to increase muscle damage when present in muscle injuries. More scar formation, more degeneration, necrosis of muscle occurs in the presence of white blood cells. Also, it's been suggested that white blood cells can increase the potential for localized pain. People have commented on the fact that in some preparations in which white blood cells are injected, they are painful. This is anecdotal. We don't know what's causing the pain. We have some ideas that it could be stimulus of nociceptors due to some of these lysosomic enzymes that are present in the white blood cells. The white blood cells have also been shown to correlate with an increase in the expression of catabolic genes, especially in tendon cells. McCarroll and Fortier produced a nice paper to show that if you increase the number of white cells, there's increased expression of the different the matrix metalloproteinases, which are degradative enzymes which have a deleterious effect on some tendon cells, at least in vitro. Now, people have said, well, if we have white blood cells, it's probably better if we have monocytes versus the PMNs or the granulocytes. We don't know what impact it has clinically, I should say, so I think the role of specific white blood cells in terms of how they are categorized in PRP preparations is still unclear. People claim that the more monocytes you have, the less perhaps pain, the less muscle damage you may have. We're still not sure. I haven't seen anything that really shows us clinically how this impacts healing one way or another. And finally, inclusion of white blood cells in PRP preparations may not have any scientific rationale, but rather may simply be a reflection of an inability of the preparation technique in question to completely eliminate this cellular component. Dohan and Maidan has suggested this, suggesting that it's the centrifugation process and the harvesting process, their inability to eliminate the white blood cells that cause this to occur. So I don't see any compelling scientific evidence in favor or against the use of white blood cells from a clinical perspective. Those studies are certainly out there, and we'll anxiously await their clinical outcomes to see if we can unravel the question about the presence or absence of white blood cells. Next, whether or not we have platelet activation, and this is usually done by the addition of thrombin. Many of the techniques out there, or several of the techniques out there, utilize thrombin to activate the platelets. Why use exogenous thrombin? Remember, we said that the chelation of calcium with sodium citrate prevents the conversion of prothrombin to thrombin. So what many techniques or what many procedures utilize is the addition of large volumes of thrombin to just put that thrombin back into the system and start the clotting cascade. The idea being is that PRP is a liquid form. By adding the thrombin, you can start that fibrinogen cascade and produce a bit more physical substance to the PRP technology. In this case here, it looks more like a gel, can look like a thick syrup, and depending on how you process it, you can get the consistency of different densities, if you will. The problem with thrombin was shown very, very nicely in a study by Hahn out of JBJS in 2009, in which it was shown that the addition of exogenous thrombin to PRP triggers an immediate activation of platelets. We said before, these are like bags of marbles in which that bag opens up, the growth factors go out and are put out into the system. Now, outwardly you think, well, that's probably not a bad thing. You've got all these growth factors there. But what happens is that activation of the growth factor, you have to recall that 70% of the growth factors are secreted within the first 10 minutes following activation, and 100% of the stored growth factors are secreted by 1 hour. So what you've done is you've introduced a whole bunch of growth factors locally. The problem with that is that growth factors that we've talked about, those 7 that we've talked about and others, basically have a half-life that ranges from a few minutes to 1 or 2 hours. They're not around for a long time. So activating a PRP system with thrombin basically will say that those growth factors would be gone by the time the patient is out of recovery. So it's perhaps something we really don't want to do if we want those growth factors to be around a long time. Now, I think there may be systems or indications that's not beneficial, and some indications may be beneficial. We really don't know. But I think from a surgical point of view, as we'll talk about, I think it's more beneficial to have those growth factors around a longer period of time, and we'll give you some evidence that would suggest why we say that. In this paper also, it showed that not only do the platelets that are activated with thrombin release all their growth factors right away, this release is actually not very beneficial to the healing process. In this graph from the Hahn article, we see here that on the right, we see the levels of TGF-beta induced by luciferase activity basically gives us an idea of how active this stuff is. We're seeing here that PRP treated with thrombin, we have this huge release, this huge concentration of TGF-beta that's released almost instantaneously. As we said before, because the growth response curve of growth factors are not linear, we find out here that what happens is in each of these 3 experiments, when you add the thrombin and you release these growth factors, it actually becomes inhibitory compared to PRP by itself in terms of the ability to induce bone, and your bone scores actually diminish. So we see evidence of an untoward effect of having that big bolus of growth factors, in this case TGF-beta, released at the site locally. Now, some techniques in the past have utilized bovine thrombin, and remember that because this is a foreign protein, people have shown in the literature that there are some ill effects to this. Coagulopathies may be difficult to treat after exposure to bovine thrombin, and bovine thrombin can induce immune-reactive coagulopathy. So people, for the most part, have gotten away from bovine thrombin, either using exogenous human or synthetic thrombin derivatives. Finally, the level of fibrin formation is something else that delineates the different PRP techniques from one another. And the idea is that this whole aspect of platelet-rich fibrin matrices is really a different type of PRP, because now we're going to focus not only on the platelets and the growth factor containing it, but the plasma component in which we can regenerate the clotting cascade and produce the fibrin, which we'll find out is extremely important in the early phases of wound healing. To get to that, we have to think about what exactly is the role of PRP in connective tissue repair. We kind of utilize it, but do we really know what we want to do with that PRP? I think ideally we'd like to provide an exogenous source of platelets and plasma and their associated bioactive molecules. Remember, bioactive molecules are in plasma as well as the platelets, to the wound site. So we have something there. We have that active bioactive cocktail to initiate and sustain the healing response. We want to optimize the healing environment. We cannot really make tissues heal any faster than normal. What we can do is optimize the environment in compromised tissues to give Mother Nature the best chance. I think I always tell the students that we're working with Mother Nature. We're not trying to do this on our own. We're trying to do this collaboratively with Mother Nature, and we want to optimize the healing environment. What then is that optimal healing environment? Well, let's take a look first at the recipe for connective tissue repair. And this could be any connective tissue repair, ligament, meniscus, tendon, bone. And we can find out that what's happening here is that this whole response is an exquisitely designed continuum of events that are really interdependent and subject to both intrinsic and extrinsic signaling. By this I mean there are things that the patient needs to do, there are things that the surgeon can do to optimize that particular healing process. And we can divide this up into 4 stages, but I really want to concentrate on the first 2 phases, the phase of inflammation and cellular and matrix proliferation, because I think these are the key components of connective tissue repair in terms of looking at the recipe. The inflammatory process is the initial process, and it requires a blood supply. Not so much about the blood supply per se, but rather what the blood supply brings in. And the blood supply brings in not only the PMNs to kind of clean up the area, the polymorphonucleosides, to clean up the area and remove any debris. But most importantly, the fibrin clot, which we can call the provisional scaffold. This provisional scaffold, as we'll find out, is extremely important in calling cells in and allowing them to migrate on a substrate that allows them to proliferate. And plus, the fibrin scaffold also acts as a reservoir of growth factors because these platelets are actually trapped in the fibrin scaffold. And these platelets then release their growth factors, they're bound to the fibrin, and this allows, as we'll find out here in a little bit, an elution of growth factors over a period of time, which we think is very, very beneficial. Now, I said that provisional scaffold is extremely important because it provides contact guidance. This is a scaffold on which cells can migrate and proliferate. And if we wanted to design the absolute perfect scaffold, well, we'd come up with fibrin. That's what Mother Nature did because it has all the attributes we really want. It provides a matrix to support the ingrowth of host tissues. It provides an inductive and conductive stimuli for cell and vessel migration. It actually calls in the cells and vessels from a chemotactic point of view with some of these growth factors like TGF-beta, like PDGF, and like VEGF. It allows for normal tissue remodeling. It's not too stiff, it's not too supple. It's there to provide that normal remodeling, and that's extremely important because it allows the tissue to differentiate along the ways that the normal tissue it's replacing did. And then finally, it's eventually removed by the host. It's not there forever, and this is the way Mother Nature designed it. So it is, in fact, the ideal scaffold, what we want. And it's nice to be able to maybe introduce that into wounds that either are compromised from vascularity or compromised from poor cellularity, and allow that matrix and that scaffold to be there initially to initiate that first part of wound healing. Remember, we said the fibrin has a reservoir of growth factors, and these growth factors, as we said before, there's a lot of them, but these are the 7 that's there. And remember, we said the nice thing about PRP is that they're provided in the necessary amounts and in the normal wound healing process at the appropriate times. Since we don't know what that appropriate time is, wouldn't it be nice to put in that whole cocktail of growth factors and have it present for some period of time to allow the cells to utilize them when they need to? And I think this is one of the advantages of a PRFM over a thrombin-induced PRP. Now, we looked at this many years ago, kind of the forerunner, if you will, of the fibrin scaffold, in terms of looking at how we can provide both an exogenous provisional scaffold as well as an exogenous source of growth factors to optimize the healing environment in tissues that had a poor blood supply, vis-a-vis the meniscus. And what we came up with when I was at the Hospital for Special Surgery with Dr. Russ Warren was the meniscus repair using an exogenous fibrin clot. Basically, then we knew how important the fibrin was. We didn't really understand that much about the growth factors or their ability to be sustained within that fibrin scaffold, but we could take 30 cc's of blood and stir it in a glass rod, which basically precipitated out a fibrin scaffold that contained red blood cells and also trapped growth factors in that fibrin. And what we were able to find out in our 1988 JBJS article was that putting this in the avascular portion of the meniscus allowed the meniscus to heal without need of a blood supply. Cells migrated in because of the chemotactic nature of the growth factors and the ability of the fibrin to act as a provisional scaffold, and then the tissue remodeled and matured into a meniscal fibrocartilage. And of course, it gave way to the idea of using fibrin clots for avascular meniscus repair. Now, if we fast forward, well, what can we do now to provide a provisional scaffold with an increase in platelets and growth factor concentration? Of course, that came about with the idea of PRP. I think it was enhanced with the addition of the PRFM, or the platelet-rich fibrin matrices that are now available. And I think these are very, very important. Now, if we think about what the difference is between just PRP and the platelet-rich fibrin matrix, or the PRFM, instead of putting in overwhelming amounts of thrombin, in this particular case, which is the cascade system, basically what's going to be happening is that you're going to reintroduce a stoichiometrically calculated amount of calcium. You're not overwhelming it with calcium, you're putting back in the calcium that was chelated. And this happens during the second centrifugation step and provides you with what you see here. Kind of looks like an egg, with the yolk being the PRFM. And we can see it has some substance to it. We'll find out later on it has some decent material properties that allows you to place it in the surgical site and maintain it in that particular position. So what we're coming up with is a platelet-rich fibrin matrix which provides both a provisional scaffold as well as a reservoir of growth factors. And we can see here in these particular images a PRFM on a suture getting ready to be placed for rotator cuff repair. In the center portion is basically a section of PRFM that we stained with PTAH, which stains fibrins, a specific stain for fibrin. And what I want you to look at here is you can see it's kind of a network, a spider web of fibers here, and you can see some nests of dark material here, which we'll show you a little bit later on, are actually platelets. In fact, we can show you in the next slide because this particular section is stained for TGF-beta, an immunohistochemical stain. And what we're seeing here is that not only does the fibrin stain brown, which is indicative of the growth factor being present, but also those nests of platelets also stain brown, suggesting that we have platelets and we have remnants of platelets, plus we have growth factors that are bound to the fibrin provisional scaffold. Pretty exciting stuff. Now, we've also found out that over the course of time that depending on the speed in which you centrifuge the PRFM, you can change the consistency and the density of this particular material. We can see here that on the upper right, 12 minutes at 1450 Gs, which is pretty much standard, you can produce a condensation and a concentration of that fibrin. But if you increase that, if you double just the time or increase the speed, always easier just to double the time, we can compact it even more dense. And that's pretty exciting. You can see here, again, a similar picture to compare it to what happens with a normal blood clot. If you just let blood clot either in the wound or in a glass beaker, you'll see what we see on top here, which is red cells that are stained, and you see those lakes of plasma. But we don't see any fibrin. It's very, very difficult to see the small strands of fibrin. If we spin it down and do that second spin in conjunction with the calcium chloride, you can see here that we're actually concentrating that fibrin and making that wonderful spiderweb network of fibrin for a provisional scaffold. Now, we actually can modify this even more by taking a larger amount of blood, in this case 18 cc's instead of 9 cc's, spinning it at a higher G-force, 4,500 Gs instead of 1,450, and doing it for 25 minutes. And what we produce here is basically a platelet-rich fibrin membrane that basically has the dimensions of a $0.50, both in diameter and thickness. We're going to see that this allows us to have a greater surface area, B, a more dense fibrin construct, and C, as we'll find out in a little bit, a material that elutes growth factors out for a longer period of time compared to the platelet-rich fibrin matrix, which has half as much blood and is not condensed as much. We can see here that same slide. Now we add the third slide in the lower right, which is the PTAH stain for fibrin, showing the condensation of that fibrin scaffold, the membrane compared to the matrix, compared to the blood clot. So it's obvious here that we can control the substance of the fibrin by the speed in which we centrifuge it. A recent study that just came out by Lucarelli from the Rizzoli Institute, very elegant study. I direct you to the far right images on top and bottom, C and E. And basically, these are scanning electron microscopy of the surface, showing, in fact, intact platelets. So even this high-speed spinning and centrifugation does not cause the platelets to become activated. Even the addition of this stoichiometrically calculated amount of calcium maintains the integrity of these platelets. And the nice thing about it, they were able to do some mechanical studies showing that it has a pretty decent stiffness, or modulus, and the ultimate tensile stress. Again, we're actually creating a more robust material here by this centrifugation step. So we have some material properties that are good for suture holding capabilities, as well as providing a bioactive scaffold by maintaining platelets intact. Now, is there a biologic advantage? I think when people talk about PRP, any type of PRP or even PRFM, the question is, well, when you're doing surgery, there is bleeding, and bleeding has been shown to be important in wound repair. So is there really any biologic advantage of these matrices over a natural occurring blood clot of similar volume? So one of my graduate students, Lance Visser, and I did this project about a year ago in our laboratory, in which we created a blood clot, a PRFM matrix, and a PRFM membrane of similar volume from each of 4 subjects. And what we were able to do then is compare the elution of a sentinel growth factor. We picked TGF-beta from each construct over a 7-day period, and then we compared the mitogenic activity of iluents from each construct over a 7-day period. And again, if you can look, it's Visser, Arnoczky et al. In Veterinary Surgery 2010. It's online publication now, so if you go on PubMed, you're able to download this particular report. preprint. And what we found out was initially that the TGF-beta eluted out at a higher concentration at both day 1 and day 3 than both the matrix and the blood clot. And we can see over the course of time, even though it's not statistically different at 5 and 7 days, we see more of that growth factor at 1 and 3 days at a much higher concentration compared to blood clot. Now, we can take a look at this on the histology, and we see again on the left-hand side the matrix and the right-hand side the membrane. You may not be able to get an appreciation for how dense that fibrin is on the membrane, but both of these show that the matrix is staining brown, and those little nests of platelets that are trapped in the membrane are also staining brown, which is indicative of a positive stain for TGF-beta. What we also wanted to do is not only find out that one growth factor, but what was the bioactivity of this eluent. If stuff is coming out of the clots, we hope it's other growth factors that are also mitogenic. And so we looked at the ability of the mitogenic growth factors to actually enhance cell proliferation from this eluent. And you can kind of see here on these images that you have a pretty good idea that both the matrix and the membrane generate far more cell proliferation than the control, which is this 2% fetal bovine serum, or what's eluted out from the blood clot. But we can actually put some numbers on this by actually doing a count of these particular cells by using an MTT proliferation assay. And what we're seeing here is pretty exciting, that over a 7-day period, the membrane always has more bioactivity, more mitogenic proliferation effect than the elution from the blood clot, which is fairly static over the course of time and really doesn't change. And both the matrix and the membrane were more beneficial than the blood clot up until 5 days, and the membrane a little bit longer than the matrix in terms of being higher than the blood clot at day 7. So what we're doing is showing you that you have a sustained release of growth factors that are bioactive over a 7-day period. Now, that's nice, but is there any advantage of having an extended elution of growth factors in this particular case? Well, I think there may be, especially in biologically compromised tissues. For example, the rotator cuff tendon, as we see here, there's a watershed area that is devoid of vasculature oftentimes. And perhaps on a cellular point of view, those cells have died and we don't have any cells there. So the cells have to come from a longer distance. They have to come from the adjacent tissues. And we need a diffusion gradient of growth factor to be present perhaps for a longer period of time to allow this to occur. Likewise, there's some great stuff in the literature that shows us that growth factor supplementation at 7 days has been shown to be associated with an enhanced maturation and an increase in biomechanical properties of healing tendons. So the idea that those growth factors are there at a buffet, if you will, for the cells to utilize as needed does have some beneficial effect and some support in the basic science literature. I think personally that in connective tissue healing, the provisional scaffold, or the fibrin matrix or membrane as the case may be, is just as important as the growth factor component of the recipe. We kind of showed this in a nice little in vitro studies we did in our lab, where we took a meniscus, this is a canine meniscus, and we made a hole in that living meniscus, and we packed it with the PRFM. And you can see already at 1 week, there's evidence of cell migration from the meniscus. Cells are being called from the meniscus into the matrix, the scaffold, the provisional scaffold that's there. They can't come from anywhere else because there's no other cells in the system. And look what happens by 2 weeks. Not only are more cells migrating in, but those cells that are already in the matrix are proliferating. So the same type of sustained release, sustained biologic effect has been shown very, very nicely here in vitro. So we think that scaffolding is really the key in some of these connective tissue repair phenomenon. This has been kind of shown and is being proven now with some peer-reviewed literature. An elegant study from Sean O'Connell has shown the use of PRFM, in this case a membrane, in chronic venous leg ulcers that were really unresponsive to standard treatment. And we're finding out that he was able to cure 2/3 of these by 7 weeks. And this is pretty amazing because these people were facing severe surgery, some amputations in certain instances. And so we're seeing the sustained release of growth factors, again, in these compromised tissues appears to be beneficial. Other people who have utilized the PRFM, in this case was Sanchez for Achilles tendon repair, and he was able to show there was less time to return to running and less time to resume training activities in the patients that received the PRFM. So the idea that you have this bioactive matrix as a reservoir of growth factors and a provisional scaffold, again, shows some benefit here clinically. Well, where are PRFM constructs being used in orthopedics today? Well, there's a couple people utilizing them. In this case, Nick Scaglione looks at biologically at-risk isolated meniscus tears in younger patients. Patients are not having ACL reconstructions, just having tears in the red-white zone. And here's a nice video courtesy of Dr. Scaglione showing the ability of Nick to put in this fibrin matrix into the repair area here. It holds and handles fairly well. Nick was a resident when we were doing the fibrin clots for meniscus repair and was a big advocate of that when he was out in practice, and now he's gone to the PRFM and has been getting very nice results. Another indication is rotator cuff tears. Leslie Anderson has utilized this. This is Dr. Anderson's technique where she utilizes a PRFM membrane now in between the tendon and the bone. This kind of shows the matrix, but Dr. Anderson has now moved to the membrane because of the longer elution of the growth factors over the course of time. Greg Finelli has utilized the PRFM in filling up the drill holes after ACL PCL reconstructions and was able to show a decrease, a statistically significant decrease in the incidence of tunnel widening, which again one would think would be important. Really no difference in the clinical outcomes, but the absence of tunnel widening suggests a more optimal healing response for the bone to grow into the tendon. Well, the question is always going to be, besides the basic science, is there any evidence of patient benefit? And these studies are starting to come out now where we see early clinical results that are encouraging. Improved pain scores from Leslie Anderson's rotator cuff study, a decrease in re-tear incidence from Alan Barber's work on rotator cuff repair with the PRFM, a decrease in the incidence of tunnel widening from Greg Finelli, and an earlier return to sport. So these studies are now coming into publication and peer review, and I think as we move on, we're going to get more information about this and give us a better idea of exactly where the PRFMs may be most beneficial. The question is that what is the quality of the repair tissue? Are we really regenerating what Mother Nature started out, which would be nice? Are we just having fibrovascular repair tissue, which Mother Nature does for these connective tissues? Or are we producing scar? This is always an issue. I think we're safe to say here, and everything that we've seen and others have reported, this is the same fibrovascular healing that Mother Nature does. As I alluded to, we're basically just helping Mother Nature, optimizing the situation, working with her to allow these connective tissues to heal. And that's exactly what we're getting. We're getting fibrovascular repair tissue. Right now, long-term randomized studies are needed and are currently underway. We need to have these to determine if and how these different PRFM constructs may augment the healing response of surgically repaired, biologically compromised connective tissues. As I said, I think biologically compromised is the issue here. I don't know that these are going to heal tissues in a normal, healthy individual any faster. We're looking at the biologically compromised, where I think the big indications for any of these P or PRFM products are. I think in summary, the PRFM construct allows for the prolonged delivery of increased concentrations of growth factors involved in the healing response of connective tissues, as well as providing a provisional scaffold to support cell migration. I think there's substantial and increasing basic science data which suggests that PRFM constructs increase cell proliferation and matrix synthesis when compared to blood clots of similar volume over time. And I think these early clinical experiences that we're seeing, and more of those are coming out with PRFM, suggest the beneficial effects, especially in biologically compromised tissues. I think, as an aside, this is a basic science lecture, but when you're looking at the clinical studies that are out there, be careful to make sure that we're actually comparing apples to apples and oranges to oranges. Variations in PRP preparations, variations in patient populations may give us different results. We have to be critical not only in the way we conduct the studies, but in the way we interpret these studies. And finally, as I noted, randomized control studies are the way to go, and they're currently underway, and we anxiously await their outcomes. So I think PRFM, a different type of PRP, is something that you really kind of want to consider based on the basic science alone. Seems to be an attractive option. Finally, in total summary here, the PRP or the PRFM preparations do allow for the local delivery of increased concentrations of growth factors involved in the healing response of connective tissues. Early clinical experience with both of these suggests some beneficial effects, especially in biologically compromised tissues. And the randomized control studies, like I said, are really needed and are currently underway to give us some idea of what's happening. And finally, and I think most importantly, as you're thinking about what PRP techniques or preparations or products you want to use, understand they're not all the same. When you're going, ask the questions of what is the platelet recovery, how much blood do we need, how much platelets do you really get, what is the growth factor concentration, and how does that relate to the repair. Whether or not you're using thrombin activation, which we said opens up those platelets and releases those short-lived growth factors almost immediately. What delivery vehicle are you using? Are you just injecting the plasma? Is the plasma activated? Are you putting in a gel, or are you putting in this fibrin matrix, which provides a provisional scaffold and a way to allow for the elution of growth factors for a longer period of time? And again, what is the duration of the biological activity? Is it hours, or as we showed here in some of the PRFM studies, 7 days or maybe even longer? I think these are important. Once you ask these questions and get the answers that hopefully you'll see from this basic science lecture, I think you'll have a better idea about how you want to look at PRP and what PRP technology you want to utilize. Thank you very much.